Next up, we have Dr. Amena Smith-Fine, who will be discussing international validation of meaningfulness of postural sway and gait to assess myeloneuropathy in ALD. We also have Bela Turk and Hemmo Yska.
Okay, we're glad everyone is still here. Thanks for bearing with us. It's been a wonderful day. And we're excited. This is a joint talk between the three of us. And we're really excited to end things up by talking about really the latest chapter in a long-standing collaboration between our institutes, Amsterdam, UMC, and Kennedy Krieger. So a couple of years ago, we found an opportunity to standardize our approach for measuring sensory motor outcome measures, such as walking in balance, using wearable sensors and a shared protocol across sites. And you've heard from others about remote testing and how that's becoming more popular in research and even trials. We also explored, it's sort of come up as a theme today about, measures that are of importance to patients, right, that are functionally relevant. And so we wanted to look more specifically at links between measures such as sway, which can be somewhat esoteric, to actually clinically meaningful outcomes that would have some bearing on day-to-day function. So again, we'll give the talk today sort of in three parts, and a manuscript is currently in preparation for submission really soon, and it's also authored by Jen Keller at Kennedy Krieger Institute and Ali Fatimi in Mark, England. Okay, so in terms of disclosures, just intermittently, I serve as a leukodystrophies educational consultant for Ionis. And then in terms of what we'll talk about today, I just want to briefly highlight the history of sensory motor measures of importance in AMN for both looking at disease severity and progression. And then I'll talk more or introduce our collaborative study measuring sway and gait in AMN using wearables. And then move on to Hemmo and Bela, which will then share some of our data on relationship of sway and gait with AMN severity and progression, and specifically look at relationships with clinical outcomes such as assistive device use, falling, and quality of life. Okay, so I don't have to repeat for this group about the diagnostic criteria of ALD, and I just want to briefly focus us in for this talk on the adult phenotype AMN. So this is the myeloneuropathy type that is really the default for all men and really the vast majority of women, at least over age 40. And so as we've heard today, we know that the dorsal columns in the corticospinal tract and the spinal cord are affected. They degenerate over time. And so as a result of, so the dorsal columns, of course, will process sensory information from the extremities. Corticospinal tracts are pathways important for voluntary motor function and tone, especially in the lower extremities. So as these tracts are degenerating, the consequence is weakness, spasticity, the sensory ataxia or, unsteady walking and balance, and bowel and bladder dysfunction, among other signs and symptoms. So I don't have to convince anybody in this room that it's really critical to monitor what's happening with the spinal cord progression. As a clinician, this is a conversation I have often with patients, especially when there's been a new diagnosis. There are a lot of questions. How fast should I expect my symptoms to change? Is my exam worsening when they come for follow-up? Is it time to start using a walking aid or a chair? And then is there anything I can do? Is there any hope of diet or medication or therapy that could slow the symptoms down? And then from a trials or industry perspective, what we want to know is what are endpoints that we can use in trials that change quickly, right? Over 6 months, a year or two. So we can use those for comparison for how effective the study drug is in slowing decline compared to placebo. So, as we know, the progression is slow and variable in AMN. And so the commonly used clinical scales that we depend on, such as the EDSS, can be really good for measuring disability or severity at one point in time. However, they're not susceptible or not sensitive to small changes, unfortunately. So there is more of a need for sensitive and accessible outcomes that can capture or really quantify the changes in the spinal tracts that result in the balance and gait problems we see with patients. Okay. So one attempt across multiple leukodystrophy centers in the last 15 years has been to develop these sensitive quantitative outcome measures using specialized equipment in a motion lab. And so as examples, these are tools that would measure things like hip flexor strength, vibration sense, balance, and walking. So of course, this equipment is expensive. It's not available everywhere. And it really requires a certain degree of operator training, expense, and really sophistication to analyze. Also, it requires the patient to travel to whatever center has that equipment available, which can especially be challenging when we're trying to do assessments at short follow-up intervals. So walking measures in the lab, often are collected with a 6-minute walk test. This is very useful in some ways. It can compare distances that patients are able to walk over time, look at walk speed. But of course, for anybody who's done this research, it's very challenging to walk for 6 minutes at as fast as possible speed. So a lot of people aren't able to do it, or at least to do it over time. So we really need alternative walking paradigms such as self-selected pace, shorter walks as well. And then force plate testing is another variable that's shown a lot of promise as a valuable tool. So you can look at just standing balance over 20 or 30 seconds. And this is ideal because it's just inclusive of many more patients, those who aren't able to walk long distances or those who require use of an aid. Okay, so just in terms of what the literature has shown us so far, in terms of how these really quantify severity at one point in time, lower extremity strength, we know hip flexor strength especially is associated with corticospinal tract loss. It's been used to assess severity of disability. Vibration sense is associated with the dorsal column medial lemniscus tract loss in AMN by imaging, and has also been correlated with activity and participation measures. Walking is really important. I can't emphasize how much we focus on that in clinic. It's a primary impairment. And, again, it's a difficult conversation when it comes to the point of, do I need an aid? Am I no longer able to walk independently? And that has implications for falls and potential injury and just ability to really get through activities of daily living without support. And then we know from the literature, as well as the excellent patient-focused drug development meeting that ALD Connect put on last year, that sway is also important. Balance is also very important to patients. And we know that correlates directly with sensory loss, and it's related to hip strength and also slowed walking and disability. Okay. So perhaps the bigger challenge really is, again, identifying sensory motor measures that are able to quantify these small changes in progression over just 1 to 2 years without requiring very large groups, upwards of 200 or 300 patients to be able to prove this. And then, of course, some variables have looked very good for men, such as walk speed and the 6-minute walk test. That changes for men over 2 years, but not for women. And so the hope, again, is that these variables will be able to access both sexes. So sway is really being focused on as one potential variable that we know changes for both men and women over that time frame. So today we're really wanting to make the case that wearable sensors are a needed and practical addition to get this information that is not necessarily tied to a clinic or motional lab, allowing for remote monitoring at any site or even at home. And to summarize these advantages, they're also really user-friendly for the participant and new staff who are being trained across sites. It allows us to capture more frequent data points, over months. Remove some participation barriers. Again, patients don't have to travel to us. There's cost involved with that, as well as just the physical burden. And then our approach has been to directly supervise the test in real time by research staff. So, and that way there's good sort of quality improvement. We can repeat tests. We're sort of really assured of the data that we're getting. So we chose the Opal system of wearable sensors. These are basically, they look like a Fitbit. I have a picture there. There's 3 of them that go on the waist and the feet. for the walking and standing balance tests. And these are really validated in different protocols for other neurologic diseases and ataxic disorders. So just to sort of conclude my part, we're going to summarize the project goals that Hemmo and Bela will talk about. First, to examine how sway and gait measures with the wearables reflects disease severity in ALD, and then to examine further the clinical meaningfulness of sway and gait in ALD. Thank you.
Yeah, so Amena kind of introduced very nicely the wearable sensors, what we're planning on doing, and I wanted to start this part with telling you something in what group we are investigating these goals. So this is a cross-sectional cohort analysis of both men and women with ALD, where the majority of patients comes from the AMC. It's 92 patients, and there's 28 patients, also quite a lot from the Kennedy Krieger Institute. And we collect the sway and gait in a standardized way at both institutions. So it's really an international validation procedure. And I think what is important to realize is that once a patient comes in and these variables are collected, over 100 variables are collected during each data point. So we cannot focus on all of these. So we're going to show you a selection of them. Something about the patients that we included. Here on the x-axis, you can see the age. On the y-axis is the EDSS. And just to make that clear, a higher EDSS represents more severity, more severe disease. The blue patients, or the blue data points, every data point represents one patient, are the males, and the orange or reddish ones are the females. And I think maybe a bit, I think you can see it. The dots are the AMC patients and the triangles are the KKI patients. And there's a few things you can see from this graph, which is, first of all, that there's a difference in the distribution of the EDSS scores between men and women. So the women are kind of in the middle scores, EDSS of about 3, whereas the men are more in the lower or higher ranges. So we have more severely affected men, and we have some less severely affected men. And for the women, it's kind of the other way around. And the other thing that you can appreciate is that the women have a higher age than the men, which is kind of logical because women develop complaints at an older age, but also because sometimes these women are recruited because they're the mothers or grandmothers of symptomatic men. But there is some selection bias in this, in a sense. So on to the first project goal, which is to assess the relationship between disease severity and sway and gait. And to start off with sway. So postural body sway is measured with a waist sensor, which is just one, I guess, Fitbit around the waist. And what it does is it registers the movement signal. So how much you're moving in a forward, backwards, and in a sideways direction. And you can see an example here. On the left side, this would be a healthy control. And on the right side, this is actually not an ALD patient, but another leukodystrophy patient. But this is just an example of abnormal sway, so to say. And you can appreciate that there's the pattern or the path of the sway is much more divergent than the healthy control. And we collect sway always in 4 different conditions or paradigms, which are feet apart, eyes open, feet apart, eyes closed, feet together, eyes open, and feet together, eyes closed. And it's important to realize that these paradigms get progressively more difficult, because if you're standing with your feet apart, you're stable. If you have your eyes open, you can compensate with your vision for a loss of sensibility that you get with AMN. But if you ask someone to close their eyes, you cannot do this anymore. So someone will start swaying more. And the same holds true for putting your feet together. So on to the results. This is the combined data from our 2 institutions. What you can see here on the x-axis is the EDSS. So 0, less severe, and 6.5 is the highest, is the most severe. And on the y-axis, you can see an example of one sway variable called RMS sway. And this is just one example. This is in the eyes closed, feet apart. paradigm. So not the easiest, but also not the most difficult. And this is for the male patients. And what you can see is that there's a statistically significant correlation between these two variables. So that basically means we see that more severely affected patients have higher sway. And this is a pretty high correlation coefficient as well. Now, if we compare this to the eyes open, feet apart paradigm, so that's the easiest paradigm, so to say, we see that there's still a statistically significant correlation, but the correlation coefficient is a bit lower than in the eyes closed paradigm. If we continue with the female patients, this is exactly the same data. We once again see that there's a relationship between these two variables, although the correlation coefficient is a bit lower than for the male patients. And if we put the eyes open paradigm next to this one, we see that there's less of a difference between the two paradigms. Moving on to Gait. Gait we collected in two different ways at our institutions. We started collecting Gait in both ways now, but this is from the cross-sectional analysis. At the AMC, we let patients perform a 6-minute walking test, which is a fast walking pace test. And at the Kennedy Krieger, a 2-minute walking test was used, which is a self-selected walking pace test. So there's some difference there. What we can see here is the data split between the two institutions because there's different walking tests. In the left upper corner, you can see the AMC data. This is for the male patients with the variable gait speed on the y-axis, which is just one of the variables collected by the Opal system. And you can see that there's a very clear correlation between EDSS. If it increases, your gait speed decreases. So more severely affected men walk slower. We do not see this correlation for the American patients. And there's several possible explanations for this. Could be because of the different walking tests that we're using. Maybe it's less sensitive to pick up on any walking or gait problems. But if you take a look at the graph, you can also see that it's only about 7 to 8 patients. Because there's just not that many males from the KKI cohort. So it could also just be a size problem. If we take a look at the females, same variable, gait speed. Here we see that there is in both institutions a relation between EDSS and gait speed, but the correlation is a bit lower than for the males from the AMC. So what we can, oh no, actually I have one more gait variable. Here we also have the data split between institutions, but on the y-axis this time we don't have gait speed, but the variable toe-off angle. And toe-off angle is basically collected every time that you put your foot down, and it's the angle between the heel or between the toes and the ground. And you can imagine that if you suffer from more spasticity, if you're less able to bend your foot, the angle will be lower to the ground. So in theory, a lower toe-off angle would be associated with more severe disease. And this is something that we see at both institutions. There's a very nice correlation coefficient. So indeed, higher EDSS leads to lower toe-off angle. And we also see this effect for the female patients. So what we can conclude from this data is that there does appear to be a relationship between the severity of your disease and the amount of sway and gait problems you experience. So that was the first part. But the second project goal that Amena introduced just now is to assess also the clinical meaningfulness. And the first way that we did that is by comparing the sway, the combined sway from both of our institutions between people who use a walking aid and people who do not yet or will not use a walking aid. And I think I probably don't have to explain this, but this is an extremely clinically relevant cutoff point. What you can see here is 3 examples of a sway variable. We have RMS sway, sway area, and path length. This is for the male patients, and all of this is in the eyes closed, feet apart paradigm. And what you can see is that the sway, the mean sway for the people who do not use a walking aid is much lower than the people who do use a walking aid. And this holds true for all 3 sway variables. If we look at the female patients, we see the exact same thing, although the means appear to be a bit closer together. But in general, we can say that sway is able to differentiate between users and non-users of an assistive device. Now, if we continue with Gait, this is only the data for the AMC patients, and the reason for that is that there's just too few male patients to really divide them between users and non-users of an assistive device. So only Amsterdam patients with the 6-minute walking test. And here too, the asterisk is not indicated, but you can see that there's a difference in means between these 2 groups, indicating that people who use an assistive device walk slower. And I think this is not really a very surprising result, but still to show you that the Opal sensors can differentiate between these 2 groups. And I think it's also important to note that the difference is larger between these 2 groups if you look at sway than Gait. Then I will pass on the microphone to Bela.
Hi, thank you so much. I'm going to make this really quick as I take us through some, complex statistical. I'm kidding. I've got 3 more slides. I'm going to take us through the end of this. I love having that joke every time. So it's my privilege to kind of tie this together and really tackle the question, clinical meaningfulness is a mouthful. What do we mean by that? Does the outcome measure, does sway matter to the patient? Is it something that affects everyday life? So, did I jump a slide? This here, SF36? This one? All right. So the first question, falling or falls in general. So the way this was asked was very simple, and the Dutch population was fantastic. It was a yes or no question every 2 weeks that they get. Did you fall within the last 2 weeks? And the way we looked at that data was to say, okay, let's look at how often they fell. So everybody responded differently over different amounts of time. And we said for each patient, out of the total number of times that you responded, what was your percentage of falls? That's your falling frequency. And then we said, does that correlate with how much you sway? And so that's what we see here. On the bottom left, we've got the paradigm. Again, this is feet apart, eyes open. Next to that, feet apart, eyes closed. So yes, the amount that individuals fell, the frequency by which they fell correlates with this derivative RMS sway. A quick aside, RMS means root mean squared. It's a derivative of how much somebody sways. It's a little bit like, speed versus the acceleration of a car. It's a mathematical derivative. And then we did the same thing for gait and also saw that gait also corresponds with falling frequency. And finally, we looked at SF36. SF36 is a well-known validated tool that looks at quality of life. It's a questionnaire that asks a bunch of things about physical functioning, your general health, your energy, your pain, your fatigue. And we said, does that correlate with sway? And this was surprising because we thought maybe, physical functioning is going to correlate with how sick are you? But seeing energy and fatigue, seeing general health, and seeing pain also correlate with sway, with RMS sway that's measured by Opals, these wearable technologies. That was pretty exciting for us. So to bring all of this together, what are the findings? What have we found out about sway, about clinical meaningfulness? So this is a little bit like a lawyer building a case, but really it's seeing whether or not the science pans out. So firstly, our colleagues have already shown RMS sway correlates beautifully with EDSS. We also know that this correlation is stronger in males versus females. So that's like the first finding for building this evidence. Then RMS sway area, and path length. So again, these sway findings, they differentiate use of assistive device. Then we just showed it correlates with falling frequency. And finally, we also correlate with quality of life findings. And this in the context of doing this at 2 sites with independent cohorts prospectively, we feel warrants our next steps, which are going to be, we're going to look at this longitudinally. So right now we just looked at a cross section, but we need to see how do these measures perform over time. And then the finding, use of assistive device, that has potential use as a threshold to be able to say, if you sway this much, and we don't know this yet, but potentially, maybe one would be suited to use an assistive device. And finally, we're looking forward to just increasing and expanding our data set. So thank you very much. I do want to highlight Jen Keller, who's also part of this project team. And a lot of our research is built on what she's been doing for years. Amena Smith for leading the project with Ali Fatimi, the team at Amsterdam as well. Thank you very much.
Thank you, doctors. We are going to have to hold questions again, so I apologize, guys.